My name is Dr. Harold Bays, Medical Director and President of the Louisville Metabolic and Atherosclerosis Research Center, located in Louisville, Kentucky, USA. I'm also Chief Science Officer of the Obesity Medicine Association and Editor-in-Chief of Obesity Pillars, which is the official journal of the Obesity Medicine Association. As far as my relationship of obesity to cardiovascular disease, I've served as a principal investigator for over 600 clinical trials. We were there in the very early development of some of the newer diabetes treatments. We were there in the early development of the ACEs and the ARBs and the calcium channel blockers. And we were especially there in the early development of the statins. And what I have found as one engaged in cardiovascular disease prevention research is where we are now with obesity is exactly where we were 30 years ago with diabetes, hypertension, and dyslipidemia. There was a bias against many of the therapies, if not patients, who had these diseases. There was a bias that should we even be treating these folks at all? Are these medications effective? Are they cost effective? All of these were things we heard 30 years ago, and we're hearing them now with anti-obesity medications. As far as the past history specific to a cardiologist or to cardiovascular disease, I can only tell you this. We have done anti-obesity medication research in the past, and I can tell you only a very small minority of these anti-obesity medications ever made it to market. Many times it's because they had adverse cardiovascular disease effects. So yes, they may have resulted in weight reduction, but when we did the cardiovascular disease outcomes trial, did not show benefit and many times showed harm. In fact, I think most people recall, all the medications that once they even made it to the market got withdrawn from the market. So it's been a very challenging, area in order to develop safe and effective therapies. So what's new? Well, what's new is specifically with regard to cardiovascular disease. And isn't that the way it was with the anti-diabetes drugs and the antihypertensive drugs and the lipid drugs? What is the binary switch that took these drugs from people being skeptical to being standards of care? What is the one event that took place? And the one event that took place were favorable cardiovascular disease outcome studies. We've not had it before with anti-obesity medications. We have it now. With the SELECT trial with semaglutide, we have now shown that in a study of patients with overweight, obesity, and high cardiovascular disease risk, that the administration of the semaglutide, yes, it resulted in weight reduction, but it also resulted in a 20% reduction, 20% relative risk reduction in cardiovascular disease events. So what does that mean now? What that means now for the cardiologist is that no longer is obesity something that I think is just something you think about on the periphery. I think it becomes an integral part of how you evaluate patients who either have cardiovascular disease or who are at risk for cardiovascular disease. The other thing, and I think this is critically important, is that I'm an endocrinologist. Okay, I've been involved in many clinical trials with regard to cardiovascular disease prevention, but I am an endocrinologist. And endocrinologists have been as guilty as cardiologists in sometimes just siloing patients. So we have diabetes patients and we only treat the diabetes. Or we have a hypertension patient, so we only treat hypertension. Or we have lipid patients, so we only treat the lipids. And I think cardiologists might say, well, I treat the heart disease, right? Or maybe I'll treat the lipids and such. Well, I think the days of siloing patients into their individual risk factors are gone. I think we're going back to the way I think medicine was originally intended, which is looking at the entirety of the patient, looking at the whole patient. And so when a cardiologist sees a patient who's at high cardiovascular disease risk or who has cardiovascular disease, I think gone are the days where you can just say, well, this person treats the diabetes, this person treats the hypertension, this person treats the lipids, and then somebody else treats the heart disease. And so I think those days are gone. I think we are all now, endocrinologists, cardiologists alike, we're all back to being primary care clinicians. That's where we're all headed. Because now we have therapies that if you have a patient that does have overweight and the obesity and the complications of the overweight and the obesity, now we have therapies that upon administration can safely and effectively improve glucose levels, improve blood pressure, improve lipids, and most of all, improve cardiovascular disease. So all I'm suggesting is, and it's an exciting new world, and if you think the existing data that we have is exciting, buckle up, because we are involved in so many clinical trials right now of anti-obesity medications with multiple mechanisms of action. It's just a very exciting field right now. The way I feel about anti-obesity drug development is exactly how I felt 30 years ago when we were developing all the newer diabetes drugs and the hypertension drugs and the lipid drugs. And it's a very exciting time, and I think we're going to be able to do some really favorable things for our patients.